So I think this was a really excellent session. We learned a lot about how to organize the intensive care units, especially in a period of crisis. How can we have an ICU, and how can we transform middle care area of the hospital, or even an operating room, into an ICU. And of course, some hospital wards could even be transformed in an ICU. And there are some important principles to respect there. Optimally, an ICU should be a closed ICU. It means that the person in charge should be an intensive care doctor. This is simply because intensive care medicine is a specialty on its own. And to really manage these patients, we should have a responsible person who is very familiar with all intensive care aspects. However, we insisted on the multidisciplinary care team, not only doctors and nurses and physiotherapists, pharmacists, etc., but also integrating the other specialists. They are very, very important. They can help the patient. They should feel welcome, and they should feel that they do not waste their time when they come in the ICU. They should be integrated in the patient management. So there is an ICU care pathway, which is very important. We need to have short-term planning. We heard about the daily goals that we need to set together, perhaps at the beginning of the morning. And we need to have long-term planning. What shall we do when the patient hopefully gets a little better? So we need to think ahead, not just for the next hour, but for the next days, if not the next weeks. So we insisted on the need to limit sedation and try to keep the patient aware of what's going on in the ICU. It comes to the humane aspect, how to explain to the patient what's going on, how to explain to the patient what the goals are, how to try to maintain some relation with the relatives using iPads and other electronic systems. This is fundamentally important as we want to prevent delirium and we want to prevent long-term weakness. So early mobilization is also very, very important, and we need to have enough people to do that. We could have to bring people from other wards, nurses, physiotherapists, and other members of teams, and explain what we should do in the intensive care unit, never forgetting that the patient is at the center of our preoccupation. The patient is at the center of our preoccupation. It's not the doctor, it's not the nurse, it's not the consultant, it's the patient that we need to care for. So we are not perfect, but clearly we are doing our best, and we need to give our best to our patients. So I will close the session here. I hope you enjoyed it as I did. Thank you.